Survey results released by the federal government in March 2018 indicate a national HIV prevalence of 1.4% in Nigeria among adults aged 15 to 49 years. That is a whopping 1.9 million people. This positions Nigeria as having the second largest HIV epidemic in the world and one of the highest rates of new infection in sub-Saharan Africa. To make matters worse, it turns out that many people living with HIV in Nigeria are unaware of their status. Even at that, there are indications that Nigeria has made good progress in scaling up HIV treatment and prevention services in recent years. Previous estimates had indicated a national HIV prevalence of 2.8%. However, as activity marking this year's World AIDS Day kicks off, the federal government has launched a campaign towards achieving zero new HIV infections and reducing stigma by 2020. This is in addition to the revised National HIV and AIDS Strategic Framework 2019 to 2021, earlier launched by President Muhammadu Buhari, are expected to be at the core of efforts to drive down the numbers even further. What else needs to be done to achieve the global target of ending the HIV and AIDS epidemic by the year 2030? This is what our guests, already in the studio, will attempt to figure out.
Thank you, Victor Azo. And indeed, we have very good guest representation here in the studio. First, let me introduce to you the Director General, National Agency for the Control of AIDS, NACA, and the person of Dr. Gambo Ali Gumel. Dr. Gumel, thank you very much for joining us.
My pleasure.
We also have here with us in the studio Dr. Walter Ugwocha, and he is the Executive Secretary, Civil Society for HIV and AIDS in Nigeria, CSAN. Dr. Ugwocha, thank you very much for joining us.
It's my pleasure. Thank you.
Also here with us in the studios is Dr. Uche Okoro, who is FCT agency for the, in charge of the FCT agency for the control of AIDS. Dr. Okoro, pleasure to have you with us on the program.
Thank you.
And here as well is Abdul Kadri Ibrahim, coordinator, Network of People Living with HIV and AIDS. Pleasure to have you with us on the program.
Thank you very much.
We'll begin the conversation with the Director General of NACA, Dr. Gumel. What are the latest numbers with regard to numbers of persons who are probably infected with HIV and AIDS, assuming we know them, and the rate of prevalence?
Let me begin with the numbers. Latest numbers show that we have more than 2 million individuals living with HIV in Nigeria. Previous estimates were thinking of number in the range of 3.2 million Nigerians. But with our recent work that we did last year, we were able to estimate with some near accurate figure that the HIV prevalence in Nigeria has come down, and it's not as we thought in the past. And the number of people living with HIV also is not as we previously assumed to be. So now we're dealing with a number of in the range of 1.7, 1.8, 1.9 million. That's what we're thinking, not beyond 1.9 million. And out of this, we have about 1 million on treatment, and we're looking to close the gap. So that is the basis for the campaign you've seen us launching on, the one we launched just on Monday, U equals to U campaign, and the campaign against stigma and discrimination, and the mobilization for awareness nationwide for people to know about their HIV status and do something about it. This is very critical because knowing status is the first stage of getting access to treatment, and getting access to treatment is the gateway of controlling HIV. Once somebody knows their status, about their status, and they start treatment, this drug wipe out HIV from their blood and make it undetectable. So once it is not able to be seen in the blood, then it is impossible for it to get out of the individual and affect other persons. And at the same time, it is unlikely that the HIV will get traction within the individual to destroy their body defense mechanism and give them the bad look that HIV used to give.
We just talked about the new focus, the global focus, which Nigeria is keen into. That's achieving zero new infection. And I'm wondering if we're doing that well with regards to reversing spread. Reversing spread, yes. What's the prompt for this new focus?
Yeah, achieving zero new infection means getting HIV under control. This is the key thing now, because once we get HIV under control, it means you reduce the number, or you actually eliminate new HIV infection. And when you eliminate new HIV infection, it means you're dealing with the number that you have. And if you're dealing with the number that you have, it means your responsibility now is to keep those on treatment. We have about 1.7, 1.8, not more than 1.9 on treatment, and now we have up to 1 million on treatment. If we can close this gap from now to next year, to about 500, 600 people, assuming we are able to identify them on treatment, it means we have succeeded in getting 90 or more than 90% of Nigerians who have HIV and know that they have HIV. That is one. And more than 90% or 90% of them who know they have HIV and they are on medication. And then we will look at those that are on medication and see whether we have achieved the last mile. And the last mile is making sure those on medication have achieved viral suppression, because that's the target. Once they achieve viral suppression, it doesn't leave them.
But are we having a burst of new infections? That's precisely what I'm saying. Are we seeing new infections, rising?
We have seen some evidence that new infection is rising, especially among the younger generation. But that's not the evidence we've seen from NICE. These are from other works that are routinely done in the country. And this is what we're trying to focus our attention. That is why you've seen yesterday's activity at the Presidential Villa with First Lady targeting adolescents and young persons. These are a group that when you have discussions with them, they don't feel that HIV now is a problem because there is treatment. So this is our problem with them. They don't also feel that they need to test for HIV because they don't feel they are at risk. And if you ask them, even if they have HIV, at least there is treatment, and now they don't need to go for services or to take care of themselves or to listen to what we want them to listen. So this is our focus now. We want to make sure we have messages that are, one, acceptable to them, and messages that are impactful in terms of working with us to ensure they know their status, and those of them that have HIV do something. And this is, I was happy yesterday, the young persons that came out to tell their stories about living with HIV. Some of them have been living with HIV for the past 10 years. Some of them mothers that were diagnosed previously without having any child, and now they have had up to about 3 or 4 kids that are HIV-free. So these are very good news.
Okay, thank you very much, Dr. Gumel. Let's bring in Dr. Uche Okoro, who is in charge of the FCT Agency for the Control of HIV and AIDS. From your interaction with your colleagues and others, how do we explain the revision in terms of the numbers and the rate of prevalence countrywide, for instance? What are those qualitative factors, or what were the new methodologies that were used in arriving at new numbers? And use the FCT as an example.
Yeah, thank you for that question. Let me start with FCT, because this is where I operate. The first case of HIV in FCT was in 1991. And right from the beginning, FCT administration has mounted tremendous effort geared towards fighting the scourge of HIV. And that has given rise to the creation of FCT Agency for the Control of AIDS, which was given the mandate to coordinate multi-sectoral HIV response in the territory under the leadership of the Minister of FCT himself. And we have achieved a lot of progress in that direction, working with our partners in FCT. FCT used to be a very high prevalence of HIV. But I must tell you that with intense, comprehensive, evidence-based interventions, with the cooperation and partnership of the HCT administration and other partners, civil society organizations, the community in FCT, we have seen that the prevalence in FCT, is reducing. My Director General was talking about NICE of 2018. FCT in 2010, for example, our HIV prevalence was 8.6%. But because of the work I've just mentioned now, in 2018, through the work of the NICE that was done nationwide, whereby 225,000 Nigerians were tested in over 90,000 households. It was the largest survey in the world, and it also confirmed those work we have done in FCT by ensuring that the prevalence of HIV in FCT has even dropped to 1.6%. So with that, we are looking at that people that are living with HIV in FCT should be around 48,000 estimate. But currently we're having 39,000 of them that are already on treatment. So we're having a treatment coverage gap of 9,000 that we're also following what the director is saying. We're intensifying effort. How can we be able to identify these 9,000 people that are living with HIV in the FCT so that we can be able to link them up to treatment and achieve.
But you have population influx into the FCT.
Of course,
How are you dealing with that?
FCT is a melting pot for both Nigerians and foreigners. Of course, it's the state of government, so we expect everybody to come to FCT. But the good thing we have done is that we have scaled up access to HIV services in all the communities. As I'm talking to them now, we have over 400 sites that you can walk into FCT and access HIV testing services. We have over 300 prevention of mother-to-child transplant centers in FCT, and over 180 sites you can go and receive your drugs if you are HIV positive. So all these things has also helped us in driving down the new infections, of course, AIDS-related deaths.
Okay, let's bring on Dr. Walter Ugocha. Dr. Walter Ugocha, listen to the statistics I found out about the subject we are discussing. 130,000 new infections in Nigeria. Out of that, we have 53,000 AIDS-related deaths. 55% adults on retroviral treatment, and 35% children on retroviral treatment. And you've also listened to both the DG NACA and, of course, the programs manager, FACA, on the progress we're making. These statistics, both from the two guests and what I've read, does it resonate with what you have?
Yes, it does resonate, because at the country level, it does resonate with what we have, because we were hugely part of the survey. What exactly happened was that we were using a modeling of just estimating number of people living with HIV and AIDS in Nigeria, and that was how we came to 3.9 people living with HIV and AIDS in Nigeria. But at a point, as a country, we had to call ourselves and say, hey, I think there's more scientific way of doing this thing, and that scientific way is actually to take a sample across the households in Nigeria. And when we did the actual thing, that's how we came to where we are now. But again, this means a whole lot of things to us.
But are we having more new infections?
Though we're not having more new infections, but those more new infections we're having is coming from a particular angle.
Okay.
And that particular angle, like we did mention, is the adolescents and the key populations. So the fear or the understanding is that if we do not close the last tap that is open. So it's just like in a room, you have 4 taps open, we have closed 3, but there is one that is still running. So no matter how we assume that we have cleaned the room, the water will still come in. So what we need to do really is to intensify more effort to ensuring that we close. And that's where it becomes more difficult. That's why we are now drawing back to saying, let's go back to campaign. Let's go back to sensitization. Let's go back to mobilization. Because it means that these 9,000, these remaining 800,000 are living in places that we have not been able to reach, though there are treatments available, or they are just not coming out. So the good thing we need to do, or the rider we need to take to strike the march, will be to reach out to them and ensure that effective campaign is there. Because if we don't do that, in a couple of years again, we'll come back to infecting more people and actually having more AIDS-related death. So it's very critical that everyone put their hands now to be able to close the last gap. Because if we don't close it, the water will still be flowing in.
You know, I'd just like to ask, because I know under the MDGs, we were able to halt, spread, and reverse, to the extent that between 2010 and 2017, the annual death rate recorded, you know, came down from over 160 to 150, which is what the statistics we have, you know, as sure. What happened between that time and now?
Yeah, so there were a whole lot of resources. There were a whole lot of resources. You know, HIV and AIDS response, it requires huge resources. There were donors from different countries of the world, you know, supporting the country's effort. MDG itself, as a global campaign, supporting the effort itself. And that's also why we are coming to say that for us to make good progress now, because the donors have come to help us and they're beginning to see that there's progress we have made. We now need to bring in our own domestic resources. The state governors...
We now have donors willing to help us out?
No, we now need to bring in our own domestic resources. We now need the federal government to increase allocation. We now need the state governors. I was happy when I was hearing the millions of millions going to ex-state governors. We need these resources to be able to effectively fight HIV and AIDS response in respective states. And us as civil society, these are major focus now. We're approaching the state governors, we're approaching the state government, we're approaching the first lady, and we're saying, hey, please, we need more mobilization and we need you to commit resources to be able to fight in the last mile, because we call it the last mile, the last numbers that are remaining, the last people that are yet to be identified, the last people that are yet to be tested, the last people that are yet to be put on treatment. Because once this is done, what we can now do is to effectively do the reverse. Because right now, there's no reverse gear yet. It is still the fact that we all out to fight. It's when we have put the last, at least we get to 95%, we can say, yes, we have done some good work. And I can now start thinking about reversing. But right now, we need to all still go out and we need to still continuously sensitize, mobilize domestic resources that when donors go, will not have issues as a country.
All right. Thank you very much, Dr. Okocha. We'll return to you. Let's bring in now Abdul Kadir Ibrahim, who is the coordinator of the network of people living with HIV and AIDS. Tell us, HIV and AIDS is no longer a death sentence. But we have heard reports that despite the availability of antiretroviral drugs and the many sites and locations where persons living with HIV and AIDS access this, it is not necessarily as easy as walking into a shop to pick up any item. That sometimes persons living with HIV and AIDS are made to part with some monies, and these monies, of course, are unauthorized. What is the experience of your members?
Thank you very much. Actually, if you are at the presidential villa yesterday... I
wasn't there.
Thank you very much. I will give you the brief. What happened is that we have young people, energetic and adolescent, that have come out openly on media to share their experiences about how they live with HIV and it's no longer a death sentence. So, issue around stigma, we have actually made a significant achievement around stigma and discrimination. And I think the entire country is now seeing the need that HIV is no longer that threat that it used to be. Treatments are available. Now, coming to the question of availability of these drugs, we have drugs. As it is in this country, we have more than enough. The challenge we have, if you look at the number of the prevalence, looking at the number of infected persons and those that are on treatment that have already achieved suppression, that's where we are having problem. If you look at, we have 1.9 million. The implication around that is that we need to do more index testing. This is what we also need to focus, apart from focusing on the young people and the key population community. Index testing is critical, looking at the fact that we do demand creation of those people that are at risk, and including their spouse or sexual partners. We need to bring them on board and get them tested as well. With that, I think we can be able to mobilize these other people to also be on treatment. For those that are on treatment, as I told you earlier, the drugs are available, and nobody, we need to make some clarification. And thank God DG is here, Walter is here. We had the last meeting around September or so, including the American government, where we talk about this issue around user fee. The truth of the matter is that we have specific items that relate to HIV treatment that is being supported by our donors, including the government of Nigeria. Among this, we have laboratory investigations. And among these laboratory investigations, we have chemistry and hematology. For the doctors among us know what chemistry is all about. If you are HIV positive before you initiated or before you be transited into the new drugs that is available, that's the TLD, you need to run food blood counters, LFT, and so on. So these charges are no longer covered by our international donors. They told us openly that it's not sustainable and they cannot be investing their money in that regard. Now, we have two key tests that are available and is free of charge. The viral load testing and the CD4 count. Nobody is charging. And we said it, anybody that charge client on these two major investigations is illegal, and that person should be reported and that person will be prosecuted. We are still waiting, and those sides that have reported were able to engage and be able to advocate, and that has been stopped in those areas that are going on. So what we need to focus on, the community intervention now, because DG is talking about the last mile, and everybody is important. And we need to ensure that the remaining people that are on treatment is not all of us that have achieved viral suppression. Out of this number, only 42.3% that have achieved viral suppression is there in the report. So what we need to just emphasize, these people are already on treatment. It's not that we are looking for them. Maybe in one way or the other, because of the community issues, they stop. So we need to do more in terms of loss to follow-up tracking and those that have defaulted, and ensure that we return them back to care to be able to achieve viral suppression.
And to Kadim, Dr. Ugwocha here talked about a particular window that needs to be addressed. I mean, apart from the issue of trying to mop up domestic funding. Of course, we saw this when the donors withdrew. Medical experts envisaged the gap in funding of HIV and AIDS treatment and prevention programs. But what, from your interaction with members of your group, what window is left to be addressed? And can you give us an insight who these people are, or what they are, or what it is?
Actually, to be honest and sincere with you, living with HIV is a very difficult thing. It's a very difficult thing, because even to even take the medication daily is an issue. However, we know the setting of this country. People are living in abject poverty. For somebody living with HIV to cope up with some of these things is actually not an easy one. What we are trying to see, the gap among PL-HIV now is empowerment. Majority of them find it so even difficult to have transport money to go to the facility and access the free drugs, life-saving drugs for them. And that is what we are saying, empower PL-HIV. Government, if they are doing their own budget, don't focus only on the drugs itself. Focus on their empowerment. Also focus on their intervention. Alhamdulillah, yesterday, mentor mothers came out to say, we work in facility ABC and there are gaps where we need to close. Our engagement is key. We are not just beneficiaries. We are partners. We are also implementers of our own program that is being designed. So the issue around community intervention need to be covered. Government need to see that issues around adherence, tracking, and empowerment, especially our young groups and women. Forget about the adult. We can go there and fish, but young people and women need empowerment, because some of these youth are out of school. And somebody that is not going to school, what do you expect him to do?
Is stigma and discrimination, is this still a factor? Is this still a barrier to accessing help for members of a community?
Stigma and discrimination actually is still an issue, but it has reduced. It has reduced. As far as I'm concerned, if I can, even though I represent a community, but with what we saw yesterday, what played out yesterday, a young person, somebody from secondary school, to come out to say, I live with HIV, you should know that issue around stigma is becoming a history in this country.
Okay, Abdulkadir, thanks a lot. Let's bring in again Dr. Gumel, who's the DG of NACA. There are a number of issues on the table from what Abdulkadir has said and indeed the other guests. But I would like you to address first the testing that he talked about. He talked about testing for chemistry from which the donors had withdrawn according to him, but that the other forms of testing are free. So how comprehensive, therefore, is the testing that we are doing in the meantime, and who picks up the bill? Related to that is talking about empowerment. We know how challenging empowerment is in our environment. So if persons who are on treatment are having difficulty accessing the locations where those drugs are, couldn't you have some mobile dispensaries or mobile pharmacies, getting the drugs to these persons rather than they waiting in one location and then the patrons are unavailable?
Right. So let me begin with the last question first. About mobile dispensaries, mobile pharmacies, we do have that. We have a program called Community ART. The first time when I came here in 2017, I think I was coming from University of Maryland to evaluate how these treatment programs are working, the Test and Start and Community ART. And we found out that they're really working for the people living with HIV, which means if you live in a certain community and is far away from the facility where you receive care, you can have an arrangement to the pharmacy shop that is near you. This drug can be made available to the pharmacy shop and you can go and receive them. But some kind of things we noted is that some people don't want to even access care in their community because of stigma. They want to go out of their state. People from, for instance, Kogi, coming to FCT to receive HIV medication, or people from FCT going to Kogi to take HIV medication because they want that confidentiality. They want some kind of privacy around it. They don't want people to know. So these are the kind of the complex we have. But we have programs that are there in the community that take medication to the doorstep of the clients or all the patients, or there are even groups within the people living with HIV. They come and then they take the medication and they distribute it to the members of their group. So these are all treatment models that we have tested, and we want to see how we can scale them up nationwide so that issue of access has been taken care of. On the issue of chemistry, which is really very important and which is one thorny issue that we have, every doctor will want to see he has given his patient the best. And as doctors, when we treat patients, we want to make sure we monitor. And we want to make sure before we initiate them on treatment, we have seen what we want to see, the way we want to see it, which means we test their blood, we do all the tests, we see these organs are fine, because these drugs sometimes could harm in certain situation. So we want to make sure that the things are avoided. But what we are getting to know now from the several years, 15 years of this treatment, is that the rate of these complications or side effects are not as we have thought in the past. And as such, we can actually do without doing this test, and we can initiate individuals on treatment without necessarily making sure, without necessarily having those tests done. And if we can do that and we have done it and it's working, the next thing is we sit down and ask this question, among ourselves. And as government, we're talking at ministry level and at NACA level to see how we abolish this test, and we work with medical community to make sure that in the interest of getting more people to take this treatment, in the interest of retaining more people, because the harm is if you insist they do, they go away. They don't take the medication, and they go away and spread the virus. And if they are on medication also, you insist they do, also they pay the money, they don't have the 5,000 or 10,000, they drop out of the treatment and they go out, and the virus now become more virulent, more stubborn, to the extent that probably your medication cannot control it. So what is the best way for us? The best way for us is to just take them, and along the way when we are treating and we see evidence of these side effects emanating, then those individuals, we can isolate them, and then we can even offer them this test free of charge. Somebody can pay, either the facility can pay, or we find a way to pay to make sure that those baseline tests are done and no harm is done.
So this is basically a homegrown solution to fill the gap, the funding gap created by the withdrawal of the donors with regards to that specific challenge. But Dr. Ugwocha, the fact that we have our national prevalence rate is quite low now. If you look across, geographical distribution, the prevalence rate is also in some states, especially in the South, is still high. We know there are states with as high as 4 or 5%. I'm wondering, that is despite the fact that those states, I don't want to mention states, have very robust intervention programs. So what could have happened?
So it means that in some of those states, our intervention program didn't actually work as we had anticipated it to work. 1. 2 is also the fact that we underestimated number of persons living with HIV and AIDS there. 3 is that also some people have actually not taken the prevention messages that we had, and we had put out across to them, and they also not been tested. And also, if you look at the pathway, you discover that most of these figures and data are coming from very far riverine areas. So difficult terrain, difficult to get by road. You'd have to do some 2-3 hours by boats. I've been in some of these communities, and also there are also community practices, cultural practices that expose women, expose young ones to HIV and AIDS, to contracting HIV and AIDS in these regions. So that's what these factors contributed to having some of those states. We call them the surge states now, and there are basically 7 of them. And intensified effort is ongoing now to ensuring that we immediately move into those places and increase our efforts, scale up a little bit more than what we have, because stigma is still a very good issue. And we are now saying to everyone that if you can take treatment very well, if you can take treatment and you know your viral load and you are virally suppressed, after a while you become undetectable. What that means is that you cannot effectively transmit HIV and AIDS through sex.
Okay, let me ask you. We know that there is within us now rising new community of people. Now, how are those communities of people fueling or increasing a spread of new infections, and how are we dealing with that?
Yeah, so this new community of people are spreading it very fast. But what we've also done is that we've got wind of it, and we have also moved in to help them to use a public health approach in addressing the infection amongst them, and making sure there's what we call the one-stop shop. Making sure, like we said before, that we move from the hospitals to making a differentiated service delivery model to them that is just unique to them, targeting to them and ensuring that we test, we put them on treatment, and we begin to pursue their viral suppression. That's one. Another one is also we have adequately targeted them again around education and awareness, because most of them, some of them are transient, some of them are mobile, some of them just want to do it. So we are providing adequate information to them. That's what a whole number of civil society organizations, community-based organizations are doing in country, to move to them and also to have conversations with them to ensure that we hold the virus.
I was just wondering, Gentlemen, I just wanted to back up a bit in terms of the numbers and the methodologies that were used in arriving at those numbers. Now, in light of what we know now, is it an exaggeration that Nigeria is having the second highest number of HIV infections in the world or in sub-Saharan Africa? Are those, classifications still tenable?
What you're looking at is the population. If you look at the Nigerian size, Nigeria is almost 200 million population. So if you say 1% of Nigerian people, you're talking of a large number. If you say 2% of Nigerian people, you're talking of a population of another country in Africa. There are countries that are 1 million. There are countries that are just 2 million. If you take 1 million, 1% of 200 million, you're talking of 2 million people. So these are the issues. It's not that the prevalence is that bad in Nigeria like in other places. No, in some places you may find up to 5% prevalence. But in Nigeria you have 1.4% prevalence. But what is the difference? The difference is that we are a lot more people. The population is high, about 200 million, and if you take that percentage, you will see it's a large number that you need to treat. We're talking of treating 1.7, 1.8 as our target here in Nigeria. Right now, we are treating about 1 million. But if you look at the burden of 1 million and the amount of money, resources that you need to put in to treat 1 million, you will see that it's very huge. The last time I was asked this question, how much does it take to treat one HIV person per year? And I said it takes a minimum of 50,000 naira to treat one HIV person in 1 year. Guess what? To treat 1 million, at that rate, you need nothing less than 50 billion naira.
I'm sure. Well, Ugwacha, you were talking earlier about governors and their millions. You said you were happy that they were having those billions or something. But I don't know. I get the point. Abdul Kadri, just before Uche Okoro comes in, what do you know from your interaction with members of your network with regard to taking the HIV treatment? Now, is it a treatment you take for life or a treatment you take for some years and thereafter abandon it? Because, I mean, human beings, we know that after a while, there's that psychological resistance or just relapse. Say, look, now something they keep person, I can leave this thing. But what do you know from your members with regard to the attitude towards popping the pills or taking whatever jabs there are?
Actually, there are a lot of improvement in that regard. Because of the counseling that is ongoing on every now and then. The key message is that antiretroviral drugs is a lifetime drugs. Once you are initiated, you continue till the end of your life. Until otherwise we have cure, you stop. Even now that people are achieving viral suppression, that doesn't guarantee that you stop your treatment because you have achieved viral suppression. And the beauty around this, some can even test it negative. Once you achieve viral suppression, when you go and do a rapid test, it may show you negative that you don't have HIV. But you need to continue to inform them about the science that is about the power of treatment and is working. Make sure that you continue and remain healthy. And in the time past, actually, people used to stop because the burden is not easy, taking it in the morning. But thank God there are improvements. Before you take about 3 pills in the morning, 3 pills in the evening, or two tablets in the morning every day. But now you can take 1 tablet in a day.
Compound tablet.
Compound tablet, and it's good to go, and it's more effective.
Dr. Uche, It baffled me when I discovered that there are actually countries, in sub-Saharan Africa, countries on the continent, who have 0% HIV and AIDS prevalence rate. And though we are still, maybe single-digit percent prevalence rate, are there context, targeted reduction programs? For instance, mother-to-child transmission, those designated special community of people, age grade and all that, country to, state to state, region to region?
Yes, you see, as we are at the last mile of achieving epidemic control, in FCT we have what we call prevention priorities, whereby we are focusing on two populations. The first population are populations that are at greater risk of transmitting HIV. These are people that are involved in high-risk behaviors. The second population is population that are also at a greater risk of acquiring HIV. These are other vulnerable subgroups that are involved in concurrent multiple serial partners, which are talking about among the youth and adolescents. And these are the two groups that we are focusing in ensuring that we provide them with quality prevention intervention services among the youth and adolescents in FCT. We also ensure that those that are HIV positive, we link them to care, because we are using treatment and prevention. Like I already said, if you are able to link them to treatment and retain them, because one thing is to link to treatment, another thing to retain them in treatment. So we do everything possible to ensure that we retain them in treatment so that we can be able to achieve that virus suppression. So these are all the things we are doing to ensure that the youth, the adolescent, sexually active men and women are what we call HIV competent citizens, which have been empowered with what they can use to prevent themselves from acquiring HIV.
All right. Dr. Thanks. Dr. Gumel, you're familiar with the story of the famous American basketballer who had tested positive to HIV. And even before the general application, as it were, of antiretroviral drugs, he was put on treatment. And after a while, he was declared HIV-free because we went for a series of tests and everything went negative. I'm asking this, and here's the background of what Abdul Kadri said, that if a person has tested HIV positive and the viral load has been suppressed and the test shows negative, is there a necessity for such a person to continue to be on medication for life, considering also what you said, that there could be some side effects?
Very good. So let me correct this. Once, except you have bone marrow transplant, as it happens with some clients in Germany and now another patient in England that have some kind of blood cancers, and they remove their marrow and give them fresh marrow. And now, when they are doing that, they were very sensitive in making sure, because these individuals are HIV positive, they get a donor that has those recessive receptors that don't allow HIV to enter. There are people that are naturally resistant to HIV, but we don't know them. Except we test them, we find them. There are few among us that no matter what, HIV cannot get entrant into their cells. Why? Because they don't have, that target where HIV is going to click and attach itself and go. They have that deformity. It's a mutation.
It's a mutation.
Yeah, it's a mutation.
It's a natural
it's a natural. It's a natural protection. So except you have that, there is no way we can say that your HIV will turn out completely after treatment to be negative. What happens is it clears the HIV from the blood, but it's still in your DNA, because what HIV does, when it goes, it enters into the cells, it takes over the DNA. So once it takes over the DNA, it converts the cells into baby HIV. And it continues to produce proteins that produce baby HIV instead of that cell which it has commandeered or taken over. So the treatment will wipe away the virus from your blood. When you're tested, your viral load will be undetectable, which means you're very good. Now we can see you're safe. It's unlikely you can transmit this, and it's likely HIV will be any problem for you. It will never show on your face, and it will never show on your body.
On the person's face,
it will never show on the person's best. It will never show person's body. Exactly. It will never show on the person's body. But if you go for that rapid test, it will still be positive. Let me tell you, some people who have gone through HIV vaccine trial, where you put some proteins that may mimic HIV, and in the course of identifying whether this protein can be good enough in fighting HIV, when you test them for HIV, they will be HIV positive, but they don't have HIV in them. Why? Because the mere presence of that protein in their body, their immune system recognizes the presence of it, and now it generates NIFAS. And this NIFAS yellow in the blood, and they will wait for that protein to come. Whether that protein is HIV, when it comes, they take it off.
All right.
Yeah.
Just a good point to take our tweets, and we have a number of them. Let me start with Adejumo Paul Ulubumi, and he tweets, the government in Kenya demonstrated good leadership and concern for citizens by making sure the ARV drugs are produced locally. It's cheap and easily accessible.
Now, Amagwala Babs has this tweet. More antiretroviral drugs must not only be made available to patients, but also must be accessible. It's an open and short fact that those who are most vulnerable are the poor, therefore need help the more. And
Abdul tweets, our religious leaders have a very important role to play, no doubt. They must continue to preach against illicit sex, and they should be able to enlighten their followers on the need to avoid having indiscriminate sex.
Well, this is coming from Titus Mondenok. I think NACA and other related agencies have a lot to do in sensitizing the population on HIV treatment and prevention, and to make the drugs free to affected patients. Mother-to-child transmission needs to be tackled head-on.
All right, Kingsley skipped this one, but I just like to read it because it's an attitude that a lot of people still maintain, even though Abdul Karim says it's no longer the case. But the Modi Haruna says, let all adhere to the teachings of our scriptures, both Quran and Bible. None of them recommend, well, fornication and adultery. They're injurious to human beings and a capital offense to the Creator.
Olawe Muyiwa tweets, the ABC, abstinence, be faithful, and the use of condom is the most common way to prevent HIV and AIDS infections, and will help in achieving zero prevalence in the country.
Daily Jack Solomon tweets, encouraging HIV testing among the Nigerian population to ensure that everyone knows their HIV status is key to any informed strategic plan. Without knowing how many people are living with the virus, it's hard to mitigate new infections and provide HIV treatment to all in Nigeria.
Now, Chris Simeon tweets, knowing your status is very important, or better still, abstinence from indiscriminate intimacy until marriage and sticking to your wife afterwards.
Munachi tweets, our government should introduce sex education from primary schools to university level to educate students on HIV and AIDS, and also do awareness via radio, television discussions, just like what we're doing now, at least 3 times every weekdays and weekends on social media. DG, which means, of course, we have a commercial advert from you on Good Morning Nigeria with regards to this event.
Adejumo Paul Olubemi tweets, the level of funding for HIV prevention and treatment is very low, ridiculously low. Now, relying on foreign donors is also unhelpful. HIV drugs should be produced locally in Nigeria.
And Jones Ferrari tweets, knowing your HIV status earlier and early treatment is the most necessary thing we can do to reach zero HIV society. Say no to stigmatization so that victims can freely open up.
Akeju Okwaju tweets, NACA apparently is discriminated against in resource allocation under the national budget. Hence, it's incapacitated in delivering services in line with its mandate.
Well, Omogbola Babs says there's an international conspiracy on HIV and AIDS. Everyone is at liberty to believe this or not. Asian and American countries with more population than Nigeria engage more in unprotected sex. Whoever has traveled far and wide knows this, yet they say we are world highest infected, whatever. DJ, 2 issues now, the issue of religion and this conspiracy on HIV. Quickly, just before we say our goodbyes.
The religious side is very important, and if we can keep to the religious teaching, it will really help us. Abstinence and keeping being faithful is very important. But for the conspiracy theory, I think this is behavior matters. Wherever you have, there are cases of HIV in Asian countries, there are cases of HIV in African countries, and even in Africa, Nigeria is not the most burdensome country. Go to South Africa and see what it is. So there is no conspiracy here.
All right.
Yeah.
DG Gambo Gumel, DG National Agency for the Control of AIDS, NACA, thank you very much for finding time to join us.
Thank you.
And let's also appreciate Dr. Walter Ugocha, Executive Secretary, Civil Society for HIV and AIDS in Nigeria, CSAN. Thank you.
Thank you.
Of course, Dr. Utoro, Program Manager, FCT Agency for Control of AIDS, FACA. Thank you.
For having me.
And Abdul Kadri Ibrahim, National Coordinator, Network of People Living with HIV and AIDS in Nigeria. Thank you. And I wish us the best of luck in our efforts to achieve zero HIV and AIDS epidemic in Nigeria. Let's take a short break. When we come back, we'll look at not every Nigerian